Hey Dave, are you able to hear me? Thanks, James. I'm not sure who's listening here. I'm just trying to confirm. This is Paul Holzheimer. When it gets to my presentation, am I sharing? I think I'm sharing my screen, but I just want to confirm. And if I need to send the slides to somebody, I just need to know who to send them to so they can drive them.
Hey, Paul, can you hear me?
We should have tested this as a webinar. Hold on.
I can. Not
You
sure
should
who's
be.
speaking. Oh,
This
hey
is
Jeremiah.
I'm in the control room.
Yep, fine. Thank you.
Are you wearing that headset?
You should be able to share your screen, Paul. If not, like you can have them sent to you.
Yeah, so I just emailed them to Dave. If you, I don't know if you have my email address or you can put in the chat box, I can send them to you too. When I click on share screen, it says host disabled participant screen sharing. I'm not sure who the host is. And so if we could enable screen sharing, I think it's probably more efficient for us, but happy to send slides as well.
It's going now.
That same message on mine. This is Jim Lynch.
Can Dave hear him then? Because he was tracked all the way.
Paul, I have access to Dave's email if we need to. I can do it from that computer. I'm all over the place here, so I can take care of that.
Excellent. I sent it to his, I think it's an iCloud.com address.
Perfect.
Yeah.
Okay.
So Jeremiah, should other presenters send you, somehow it changed my name here, if I can fix that. Should other presenters send their slides to you as well?
No, I don't believe we need to have that. Again, I think I have the ability to allow you to share your screen. That's how we did it last time. We're going to run that first. If not, we'll do the secondary as I share it for you.
Perfect. All good?
awake before, you're awake now. Welcome from the studios of CBS 2 News in Boise, Idaho. This is the first webinar of 2022 for One More Day. Of course, One More Day is a nonprofit dedicated to suicide prevention. I'm Brent Hunsaker, and with me is David Connolly. He is the founder and executive director of One More Day. Right off the bat, David, let's talk about who's in the audience today. And I guess you've got some housekeeping too.
Yeah, it never ceases to amaze me, the caliber of people that show up for these. We've got everybody from, especially here in Idaho, we've got both of our senators, our congressmen are both on board. They're staff members. We've got our state and local. We've got 4-star generals who are driving and still listening to us. I mean, it absolutely amazes me. We got folks, our partners at the Legion National. I mean, it's just amazing. And a couple things that we've got going on that we want to talk about are we're about ready to start the trial phase of our standard response protocol to suicidal ideations. That is going to be huge. We're looking at really changing the face of suicide prevention. And, this is definitely the little engine that could type scenario. Well, we're working with some of the biggest names in the industry. Dr. Rudd, who's on this with us, is one of the experts, and it really promises to do some additional good.
And while you're here, let's introduce the topic of the day. Obviously, we got a hint of that in the video introduction, but we're talking PTSD.
Yeah, post-traumatic stress. It affects so many of our service members, so many of the family members. We even had an interview the other day with one of the biggest experts there is, Dr. Barbara Van Dalen, about the effects of PTSD on the children of people battling PTSD. And it's pretty significant. And so, that's the beauty is we did 10 different webinars, or not webinars, but podcasts on the way here with different experts to help everybody. So if you want to know anything about it, on Spotify, just search for One More Day podcast. There's 10 episodes. They're awesome. We really appreciate all of our guests who did that with us. And beyond that, we've got a heck of a day lined up for you. We've got, the 2 speakers who we'll talk about in just a second. And then we're bringing to you 4 different programs this year that I think are really, they're the top in the nation. They really are. They're different views on how to address PTSD, and just, different philosophies from some of the best experts. So I think we're going to do some good today, and let's go.
Yeah, let's get it started. Let's talk about our first presenter today. He is, I don't know how else to call it other than an American hero, Delta Force Command Sergeant Major Tom Satterlee. Tom is one of the most decorated special operations warriors and was involved in thousands of classified missions, protecting the vital interests of our nation and protecting his brothers and sisters in arms. Obviously, we can't give a full report of those missions.
No.
They're classified.
He can't even.
But his first, I am told, was the Battle of Mogadishu. I don't know about you, but I saw the movie Black Hawk Down, and I still can't even begin to imagine what it would have been like to be there in that battle. But as bad as that battle was, Tom tells us that, well, he didn't face his worst foe until after leaving the military, and that was PTSD. Tom, like many of our warriors, was haunted by post-traumatic stress disorder. And Tom is joined today by his wife, Jen.
Yeah, and to be honest, she's just as much of a badass as he is, just in her own way. She was a special operations photographer embedded with SEAL teams on their live training exercises. Hell, I wouldn't do that. But she also wrote a great book it's kind of a how-to guide, I think, on being a spouse, being a family member of someone who's struggling with PTSD. So the way we're setting it up today is we've got both of them joining us, and then following them is going to be one of the top PTSD minds who can really talk to us from the neuropsychological side of it. Why does this happen? How do we reverse it? And just to give us all an understanding of why it's happening.
But right now, we want to turn it over to Tom and Jen. It is an honor to have you here, and the floor is yours.
Thank you so much. It's definitely an honor to be here. I see a lot of doctors on the board. It makes me a little nervous and sweaty, but we certainly appreciate the invite and the ability to share our story. you spoke about secondary post-traumatic stress, which is a lot of what we deal with. But I think what we typically do is start with kind of the path of how I got there, you know, a little rundown. Everybody loves to hear the war stories, which I like to get past the war stories and into the healing, but that's how you reach people to understand, oh, yeah, I did that. Oh, yeah, I might feel the same way, and I might also need some help. So like you said, my career started out, I did 25 years in the military. I did 20 in Delta. And my first mission, as you pointed out, was in Somalia and Black Hawk Down. And we actually conducted 6, I think, or more missions in that 3-month period. And the first 5 were what I thought combat would be like. You know, you go out, America wins, right? We come home, all our guys are together, we high five and we tell the stories. And it was scary at times, but nothing like 3 October, which really changed and shaped not only how the military does mount training and exercises and actual combat, but how I lived my life and how I decided to either move on or I would end up dead, right? Living the same life that I'd lived. So those tools that all those years I was taught to keep me alive, I had to let go of. And that's one important message I want for people who listen. You can let go of those tools you've been taught and pick up new ones. And it's not asking for help, it's asking to be retrained. You want to be retrained, right? So most people won't ask for help because they feel like it's a sign of weakness when they don't stop and consider that their entire life, they didn't know things until they were taught by someone else. And this was just yet another one of those things I didn't know until somebody else taught it to me. So that's what I want people to open up on. But Somalia on 3 October was one of those days started out like normal. I mean, up until, you know, infill. Infill was a bit different. And it started out with immediate fire, immediate RPGs. And the brownout was so bad that I was inserted outside of the Ranger perimeter myself. My whole team was. And so we had to fight our way in. Basically, by the time we fought our way into the target area, the target was over. As typical, you know, all right, time to go home. No big deal. We started joking about lunch, rounded up the almost 20, nearly 20 detainees that we had. And I started cracking jokes as I always did. And, you know, for 30 minutes later, we have another Black Hawk shot down right over top of us. And we knew the mission had changed. As young as I was, I knew the mission had changed. And to clarify the stories between Somalia and my later in life was I learned later in life, too late, that when you're young and all you have to do is run around and follow orders, it's not as difficult. I found out being in charge of people and having other people run into danger was very much harder on my health. But Somalia was a horrible day of experiences of repeatedly realizing that just because you're an American doesn't mean you get to go home.
No timeout.
No timeout.
No.
Americans don't always win. You know, I throughout the night, I kept thinking, why don't you just let us go home, right? Well, just let us go and we'll go home and leave us alone. And to feel trapped and the inability to go home was the scariest thing for me. I think at some point in the night, I had asked my team leader, after a couple of holes had been blown into our building that I was in with rocket propelled grenades, multiple Rangers had been shot and we had drugged them into our house and we're working on them. Other people had died across the street. I didn't know where anyone else was really. We were strung out on the entire street. My team and another team across the street were the furthest north of everything. So we took the brunt of it. And I asked my team leader when I could hear the convoy with a heavy volume of fire ringing through the city for hours. He walked in the room to check on me and I just looked up and I said, hey, are they going to make it? And his answer was basically, I don't know. And he turned and walked away to go do something else. And I was thinking, wow, that would have been a great time for a good motivational speech, right? But you don't get it in the real world sometimes. You just have to pick yourself up. And I think that's the moment I resigned myself to the fact that I was going to die that night. And for that night, it made everything easier. It made as easy as it could be. It made everything a bit more manageable. It took away a little of my fear. And I felt, well, I just gave it my all and I'll do as much damage as I can do and save as many of my brothers as I can. And spoiler alert, I made it out of that, right? So I move on through my career thinking, I'm never going to let this happen again, right? I will never be that untrained. I'll never be that unready for something. And so I put my head down and I worked my way up through the unit. I became a team leader, obviously, and became an instructor and then a troop sergeant major, with the attitude and mentality of I'm going to never let that happen again. And then I took over a troop, right? We've been at war. Well, we were at war for 20 years. And I took a troop over to Iraq multiple times. And I found out that it was the same. It was still the same. The fear, the panic, but it was worse with me being in charge. And one night out of Baghdad, launching on a mission that I'm in charge of, we had a Black Hawk shot down on infill that did a real hard landing about 100, 200 yards away. And I had to send all of my Rangers to secure that. And meanwhile, we were taking fire on the target area from multiple locations. And I realized at the moment on the radio that I was the one calling Black Hawk down that many years later. And it hit me that all those years of this will never happen again. Here we are, and it happened again. And I've had a lot of conversations since then with people who are in, people who are getting out, people who are out. And I continually hear that, well, come on, Tom, you know that we don't really get hit by this until we get out. Just absolutely false. Post-traumatic stress comes when it comes. I don't think, in my personal opinion, it's a singular event. I think it is a stack of events. For some, it may be a singular event. I think for me, it was multiple events over multiple years. And then I have the post-traumatic stress disorder that everyone talks about, and it was one of those things I denied. I was a warrior. Of course, I was trained for this. How could I have post-traumatic stress? I'm in shape. I was in Delta Force. So I don't have these things. And when I got out, the VA told me I didn't have it. And I went, all right, we're good to go. Until problems happened. And then people start paying attention. And when you start paying attention to what's happening to your life and you start paying attention around you, and I realized I've been divorced 3 times. And I don't think I can blame it on my 3 ex-wives. I started looking inward like, wow, I think I'm the problem. Shocker, I think I need to get to work on myself. And that's when life started turning around for me. I had retired. I moved to Amman, Jordan for 2 years. And it was one of those party 2 years of hard work, but yet I partied hard. And I was right in the middle of my post-traumatic stress. I'm in charge of 10 other people training foreign soldiers and living a life of retirement thinking I've got this down. This is great. I was a complete and utter train wreck in charge of 10 other train wrecks who didn't know it. And we just supported each other. And that is another key takeaway from this is when I met Jen, we didn't really know each other. And we were working in Ohio. And she was in the car with me, and 2 close friends were in the car with me, and we were driving back from a job, and we're all retired. Well, the 3 of us were retired out of the military, and Jen's still working. And we're driving back from our job, and it just hit me that, man, I am just a burden. I'm in the way. I'm no longer needed. Everything I do, I screw up. All I do is drink and complain about working because it gets in the way of me having a good time. And I decided in that 5-minute drive that, you know what, I'm done. I had a pistol in my bag, as I always did. And when we got to the parking garage and pulled up, my 2 close friends were in the back seat. See you in the bar. And I'm like, yep, we'll see you in the bar, right? And Jen got out and she's like, are you coming? And I said, I'm going to make a phone call. I'm going to make a phone call and I'll catch up. And she looked at me and she knew something was up. My close friends were already down the hallway heading towards the bar. As soon as they all left out of sight, I pulled my pistol out and loaded the round in the chamber and sat there and just had the weirdest thoughts. It wasn't about, combat or I lost Bob or Bill in combat or this or that. It was simply, I'm in the way. I'm not worth a thing. And all I do is create problems. And since I can't fix this problem, which is what I had done my entire life, I decided I would remove the problem and therefore the problem would be gone. My phone started vibrating repeatedly and I had been ignoring it. And then finally it got to the point I picked it up and looked at it and all I saw was you're late. Immediately, I snapped back into work mode. Immediately, I knew that I had somewhere to be. I felt important and I'm never late for anything. I cleared my pistol, put it away, and I stormed off, found Jen, who had been texting me incessantly because she knew something was off. The point being, she wasn't in the same bowl of crap with me, lost on the same journey like me and 10 other instructors in Amman, Jordan, all train wrecks. She wasn't the train wreck. She was from the outside looking in and she saw the train off the rails and she knew to do something. And it was so simple as a text that interrupted my process, that saved my life, that always brings me around to telling people that If you Google and look up people who commit suicide jump off the Golden Gate Bridge, not many live, but to a person, those that have lived jumping off the Golden Gate Bridge say the exact same thing. They regretted it the second their hand let go of the rail. So we started All Secure Foundation. I'm going to let Jen jump in and talk about what she saw, talk about the nightmares that me, the SEALs, the SF guys, the Rangers that she worked around, and then the spouse situation, the secondary post-traumatic stress, and why this mission is so much bigger than any mission I think I've ever been on. This one is so much more important, and it's so much more difficult to get other people who need help and may not realize they need help, or be lying to themselves that they need help, or just afraid to ask for help or retraining, and they won't do it. We can't save the ones that commit suicide, but there's so many more out there that need help, that are suffering, that haven't yet committed suicide, or maybe are just suffering and won't commit suicide, that need help.
Yeah, so I, loved my time working in special operations for about almost 4 years, embedding with SEALs, Green Berets, Rangers, as you know. And as you said, I was from a totally different world. I had spent my career in film, photography, advertising, and design. So just about as far from one side to the other that I could have started working in, and immediately noticed a lot of things that were normalized in the culture, normalized in just ways of being, and this is what warriors do. Yet that same behavior that was given permission, I noticed, were some of the same reasons that people were either entering into severe depression, loss of career, or worse, loss of life. And so I started talking to the guys really just during downtimes. We would have sometimes 4 or 5 hours while we're waiting for the client to come. And so I would talk to other operators, other service members about their time. And sure, I would hear some war stories, but primarily what I was hearing very consistently across the board was, why am I behaving so different than I was before? Why am I angry all the time? Why do I get upset about the little things? I don't know how to control my temper with my wife or my kids. And I'm saying things that are coming out of my mouth. And as I'm literally saying them, I'm thinking, shut up, shut up, shut up. But the words keep coming. I don't understand what's going on. I'm about ready to go through another divorce. I'm on number 2 and I'm 28 years old. So I was hearing this not once or twice, but literally hundreds of times. And so towards the end of my time embedding with the teams, I said, listen, we need to start something to support people on the home front, because this isn't just our journey and our story. Our story was so incredibly common that when I found someone who didn't have a similar stories to us, it was actually shocking. Some of the behavior of infidelity or reckless drinking and driving, things like that had become very commonplace in the culture and the community, like I said, were the things that were causing all the issues. We had one guy who was a very, very heavy drinker. Everybody knew he was a very heavy drinker. Nobody ever stopped him from leaving the bar. Nobody ever talked to him about it. That's not what we do. Yet this exact same warrior got a DUI, removed from his military service, got a divorce, and was suicidal. So we could see where some of these patterns and behaviors are leading to suicidal ideation, or worse, like we said, suicide. So we started All Secure Foundation, not just as a veteran or active duty suicide prevention. What we're really trying to do is help people understand, like Tom said, you can retrain your brain. You can get to the other side of whatever the source of the trauma was. Like Tom said, he had complex PTS from war. I had complex PTS from growing up in an abusive childhood abuse, and sexual trauma. So my trauma was not from war. However, a lot of our behaviors, things that we had done in our lives and in our past, were very similar. We had a similar, not story, but a similar outcome, I guess. And so Tom and I both had to get to work on our trauma. And that led to another realization of how many of the spouses have secondary PTS. Tom and I go around the country and we talk to different bases and groups. We always ask, who's heard of secondary PTS? And maybe one hand will go up in the room. People don't even realize that they're bringing war home. And war could either mean from a service member, it can mean from a first responder, someone who has a very, very high stress job, and they're bringing that energy into the home. We have so many guys say, hey, listen, I don't want to talk about what happened over there because I don't want it to affect my family. Unfortunately, it's affecting families, whether you're talking about it or not. So it's actually better to have those conversations. It's better to open up those lines of communication. I know for you, people will always ask, what was the first thing Tom did to heal? And you know, his story about the suicide was 2 years before he was willing to even ask for help. He kept digging a little bit further down into rock bottom to the point where, and frankly, we probably wouldn't be here if he didn't get the help, not just him, but neither of us. And I think that's something really, a conversation that needs to happen in this country, are the women, the children, the men that are affected, that are spouses and children of our war fighters, our first responders, who don't know how to cope with the trauma, who don't know how to handle the eggshell situation that they're living in. We don't have a guide or a resource book either. So that's really a critical and important part of our organization. So we're not here just to help the service member heal. We're there to help the entire family heal.
My first, and now that I've gone through the process in an improper way, since we stumbled through ourselves, my first bit of help was anger management. I mean, I had outburst issues. I still have outburst issues, not as bad, not as much, but I still have those issues, and it's all in the brain. And all of these doctors can talk about how to work through it. And we'll talk about some of the modalities that I went through as well, but you have to tackle them, in my belief, in an order that you can manage them. Some people are like, I have this, I drink too much, I'm abusive to my spouse, I have suicidal ideation, I have this and that. I want to tackle them all at one time. I'm thinking, good luck, right? Good luck. I took them down one at a time, and I started at what I thought was the top. And that
it's like eating an elephant.
Right, like eating an elephant, right? Everybody knows that. I had made a sandwich of meat, being everything I had created in my life was another slice of meat, and I didn't eat it. I didn't swallow it and process it until one day. And that one day I had to eat that whole sandwich in one bite, and it choked me. And it was so hard to do, thinking about everything I needed to work on. I had to pause. I had to work on one thing at a time. I started off with anger management, and during that process with that counselor, started talking about, oh, I think maybe I'm an alcoholic because I drink all the time. And so here, describe your drinking. I described it drinking. You're not an alcoholic, you're a problem drinker. You can stop if you want, and you just choose to dose yourself with alcohol. And some people drink to sleep. Some people drink not to feel. Some people drink to feel. I don't know why I drank, but I just kept doing it. And again, another pattern that I had developed. And we don't realize that we develop these patterns. We develop the aggressive attitude, right? How do you answer questions? And I'd be talking to Jen excitedly about a topic that I was happy about. And she's like, why are we fighting? I'm like, what's wrong with you? She said, it's all in the presentation. This is what I hear about. It's not what you say, it's how you say it. So self-awareness. And that's what I scream with everyone, is self-awareness and accountability. Again, until I start pointing my fingers inward on the fact that I can't help anybody else and no one else can help me. Nobody can save me. Nobody can help me. They can show me the tools. They can give me the tools. They can be the lighthouse, but I have to do all the work. So I took the accountability of it, did all the work, and started, processing things. Anger management led me to, oh, maybe I'll stop drinking as much. Just that challenge led me to,
I think
meditation. Right? Transcendental meditation is a great tool. However, I didn't use it in the proper order. I went second with transcendental meditation, where I'm still this commando in my head. I'm still this bad warrior that doesn't really have a problem. I'm just appeasing my soon-to-be wife, I hope. And, maybe I had that thought process and I got into it and it worked a little bit. But I think now I'm ready for something more like that. I can go back and do that, right? It worked a little bit for me, got me further down the path. Whatever it was, Jen was able to remove the excuse, and I sat and I listened. I thought, those are excuses, right? She's like, why don't you replace can't with won't? I want everyone to think about that. Whenever you say I can't, replace it with won't, and then reconsider that thought process. So I replaced it with won't, and I realized, well, there's not much I won't do. So I went out and and then I did TMS, right? I don't know what order I've done yoga, I've done acupuncture, and then I went into TMS, another modality that got me down the road a little further, got me sleeping better, got my head level a little bit more, And then
it's been a constant string of treatments. And I think that's really important. We did SGB this summer, both of us. And I'd encourage people who have secondary PTS to also look into that. Not only as a caregiver, you end up looking for resources for the person that you love, but I encourage you to take those same steps and those same treatments for yourself as well, because it's so necessary. We see caregivers fatigue and burnout. That's a real serious problem too. And so that causes more disconnection. It causes more issues. And I think what I was going to say was the very, very first thing I think you did, and really, I think it was from our show with David that I realized this was the first sharing of Mogadishu, that he hadn't shared the story for 20 years. And as we sat in a cafe, Tom talks about in the opening of his book, when we sat in a cafe, Tom talked about Mogadishu for the first time in 20 years. And it was excruciating for him to get through
To
it.
somebody else, to someone else, you know, to my brothers, you know, on 3 October every year, hey, miss you, yeah, you know, here's a drink, here's this or that. I had never really talked about it.
Like in detail, the story of it.
Like let it go, or to, yeah, in detail, right? In full detail to someone who wasn't there. So you have to go into full detail. That was my first therapy, was sharing the story. And that was, you know,
It was a great start.
here I am on the street in St. Louis, bawling my eyes out, looking around like, what's wrong with me, right? And I get that a lot. What's wrong with me? A lot of my friends who are experiencing repressed emotions, and they're starting to, you know, move out of that. The joke is, you know, I watch home improvement shows, and I'll, you know, in the end, when the big reveal, and I'll start crying. It's like, what's wrong with me? I never cry. You know, I don't cry about funerals anymore. And it's here I'm crying about something good that's happening. You know, empathy. I had lost empathy for a long time, and I want everyone to hear this. Consider yourself and whether you've lost empathy when you enter into arguments, and which we call discussions, heated discussions and passionate discussions, which to most are arguments, right? So consider how you're doing it. Consider how you're telling it. Consider where you're coming from.
Well, and the stories, you know, to go back to that, I think it's so important because David and I had talked about just about a week ago, a lot of people have a really hard time asking for help. They believe it's a sign of weakness. It's just difficult to do for anyone. You enter an alpha kind of machismo culture and it's 10 times harder. So, you know, don't think about it as, hey, I've got to take, like Tom said, this step where I'm tackling 10 different things. Manage your expectations. And maybe the very first thing you do is share your story. Just like Tom sharing it with me. He, you know, we weren't married. We were probably dating for a few months at the time. And, you know, it was one of those moments where he really revealed a big part of his life to me and let me in on that vulnerability, which sort of, you know, was the thing that kind of cracked his mask, cracked that shell, which would take years to kind of unpeel and to remove. So have patience with yourself when you're going through this process. Have realistic expectation of where you're at, what you can do, how much you can get done, because baby steps still lead you to the top of the mountain. You can get there. You don't have to tackle it all at once. Like I said, you could start small. And in that first small step, we see it at our retreats at Camp Homefront. It's sometimes just the sharing of something that happened in service, not maybe 10 years of it, but a particular story. And we'll see couples completely crack and open up to each other in ways where they're saying, hey, we haven't felt this way or talked this way in 10 years, maybe 20 years, maybe ever. Maybe I haven't seen a spouse like Tom cry in our relationship and our marriage. And, you know, this weekend I've seen him cry 3 times because the stories are coming out, because that shell and that mask is cracking and allowing somebody else in. And that's incredibly powerful and incredibly healing as well.
Think about the story being healing for this person telling the story. But when you're telling a story, and every time we're telling a story at a retreat or on stage, and we're talking about something we've done, you'll see this in the audience. You'll see spouses looking over like, yeah. You're not the only one that's done something. You're not the only one out there that's committed a crime, that's said something horrible. So when you hear that other people have done it also, you start to feel less alone. You start to feel less weird about yourself. You start to think, oh, this is not normal, but it's more normal than I thought. And maybe I should go out and talk to somebody about it, right? You start seeing those elbows, and that helps remove excuses. And that's what we do, I think the best is remove excuses. I get a lot of, well, I can't talk about what I did. Okay. Don't talk about the things you can't talk about. If you're sharing a story, you don't have to share where it was, what it was. And if you're worried about your spouse not liking the gory parts, don't share the gory parts. Share how it made you feel. Share the emotion behind it. Share the moment up to what you're comfortable sharing as much as you can, but start. You have to start sharing, and then you have to open up and be honest. All right, I talk about that self-awareness, that self-assessment, that owning of it. Until I owned it, I didn't get started. Removing those excuses of, well, where I worked and well, I want to protect my family. Your kids know, right? Your kids know when you're fighting in the house. Your kids know when the mood is off. Your spouse certainly knows. Now, what story are they building in their head if you're not sharing what's really going on? What story do they build? And it's typically a worse one.
Yeah, I know we have a few minutes left. And so I want to encourage people, if you have questions offline for us, we're at allsecurefoundation.org. We're here to support, to answer questions, and to provide help. And also, I just think, it's so important, and Tom and I always talk about this, is just to be open, vulnerable. There's a lot of great resources. There's some amazing doctors that are going to talk today after Tom and I, who are going to share with you the information that's so critical to understand and to start your journey, whatever that looks like for you. They're all different. Everyone's unique here. Everyone's story is different. Everyone's level of trauma or how they want to approach it is different. So again, be patient with yourself, be diligent in this. It will take time, but you can get to the other side of it where you're honestly living proof.
Don't compare. Comparison is the thief of healing. It's the thief of joy. It's the thief of everything. So don't call and say, my story's not like yours, or my combat wasn't like yours, or I didn't make it to the level you made it at, or I wasn't in the unit you're in. Who cares? I don't care. So that takes away one excuse. If I don't care, then go ahead. Share it. Reach out to us. Reach out to anybody, right? Reach out to somebody, but own it up and don't judge yourself. You'll be the harshest judge on yourself, and anyone else will be. And if anything I could do is to remove the excuse of you not asking someone else's advice in a matter, if it's help you can't do. And realize one thing, when I hear people say I was a warrior, I was airborne, I was a Green Beret, I was a SEAL, whatever it is, I was trained for this. Consider what you were trained for. You were trained to go to war, do horrible things by doing them repeatedly, removing muscle memory so you can actually do horrible things while doing something else at the same time. But you were never trained as an individual warrior how to deal with that. So when I have people saying, I don't need to talk to a therapist unless they've been to war, they won't understand it, I joke with them. I go, well, then she doesn't want to see you unless you've been to school for 8 to 12 years. Right? So consider the support in the world for you. They don't have to have done what you've done, but they know how you feel and they can help you. So take away that excuse and just reach out, and don't wait till something is so broken. It takes so much more to fix, to go get help for it. Go before it's horrible. Go before it's much more time to fix it, just like they taught you in the military. I want to thank everybody for your time, for letting us speak, and for this opportunity. And I hope you enjoy the rest of this, and a lot of good speakers coming up.
Thank you.
Well, and certainly we want to thank you for sharing with us. But before you go, can we ask you a few questions?
Absolutely.
You guys know I love you both. I mean, I am so honored to have had that. This has led me to knowing you guys, and between bawling my eyes out like a little girl when Tom was talking on our, on our first conversation, and then again on the webinar, even I've learned that you got to be willing to talk. And that's one of the things Tom and I and Jen and I are both talking about, is the whole story concept. Just start by just talking. Tell your spouse, like Tom said, just tell them what you feel. Tell them how this made you feel. And, we're waiting. We're trying to give some people in the audience a time to ask questions if they have them. But I think the biggest thing that you guys said that really changed me was tell your story. That if there's anything that's out there that we can talk about and push hard, it's tell your story. Your wife, your husband, they are your partner. Make them that way. If you leave them out, that's not a very good partnership, and it's going to end. Include them in your partnership. They'll include you. Jen, you said something that was awesome. I don't know if you remember what it was that got me so well, but it was, I had to realize that it was not my journey. Tom had to walk in his own shoes to get to that point. And, for a spouse to realize that and be part of that and still okay with that, that's a huge thing. So like I said, thank you guys so much for sharing with us and being involved. I really want to, Arsenal of Hope is, I think so hard that we need a how-to guide on, what my wife, what my husband, if I'm married, if my husband can do, what my partner can do. And that is what Arsenal of Hope is all about, right?
Yes, absolutely.
So take a look at the book, Arsenal of Hope. Take a look at, both of them have great books. Both of them have done a lot in this area. Tom, you said another thing that really, really got me from the start is when you mentioned about comparing. First thing I said to you when we started talking and I got my butt chewed for it is, hey, my story is nowhere near as bad as yours. And he shut me down immediately. Stop. Your story is my story. Just we have different variations. And wow. So again, thank you. Not showing any questions yet. So I don't know if they're coming in via our other ways or where they're at.
Let me jump in and
Yep,
ask a
please.
question myself, and that is, Jen, you talked about the secondary PTSD. How does that differ from primary PTSD, what you went through versus what Tom went through? And is coping with secondary PTSD different fundamentally than the primary?
Those are great questions. So secondary PTS can look very different. And I think that's very confusing to spouses sometimes. So what I hear and what we hear at our organization a lot is spouses will call and they'll say, listen, I know my husband has PTS. I know the things that he's been through. He has nightmares, he has flashbacks. He might have issues with violence or aggression. I don't have any of those things. So I'm okay, right? And I'll say, well, how do you feel and what's going on in your life? Well, I've started anti-anxiety meds. I've started depression medication. I've started avoiding family and friends and really have isolated myself. And I say, that's what secondary looks like. So it can look very different, and it can even look different from spouse to spouse. That's why it's so important to constantly be in that state of assessment and awareness.
And it can be different, I'm assuming, for children as well.
Absolutely. And I'm so excited that you have these amazing doctors on today who can really kind of get to the heart of it and explain it, because I think knowledge is power. And I know for me as a spouse, I was so confused. I was so frustrated. I kept asking, I'm a veteran spouse, so I was not with Tom when he was in service. So I kept asking like wives, like, hey, do you have a manual on how to handle this? And nobody did. So I thought I'd write one, at least start one.
And I hope a lot of families, a lot of spouses and partners can get that book, because I think that is so essential in what we're doing right now. And another thing that you guys said that I know we've got our next speaker coming up, but another thing that you guys said that's really important is, and when it comes to a crisis, it's the little things that can really change the trajectory. For Tom, it was the text messages. For a lot of us, it was a phone call. It doesn't have to be an extravagant thing. It can just be as simple as calling, hey, I love you, man. What can I do? How can I help? And then shut up and listen. And that's the key. Tom, Jen, do you have any other questions?
No, you were talking about maybe a manual for secondary PTS, and I think the title of that manual should be Can't versus Won't. I love that phrase. That was one of my big takeaways from what you talked about today. Ask yourself, is it I can't do it or I won't do it?
All right. Well, let's thank you guys again, and we will talk to you guys really soon.
All right, thank you.
Thank you.
Tom and Jen, thank you. Now, our featured expert this afternoon, we're moving on now to Dr. Paul Holzheimer. He is the Deputy Director for Research at the National Center for PTSD, as well as a professor of psychiatry and surgery at the Geisel School of Medicine at Dartmouth Hitchcock Medical Center. And Dr. Holzheimer will be discussing the neuropsychology of PTSD, some current treatments, and what other treatments are on the horizon. And one way to get started is Dr. Holzheimer, Tom mentioned a second ago about the retraining of the brain. Is that what you're talking about here? The retraining, the rewiring, if you will, of the brain?
We definitely will touch on that a little bit, and we can talk more about that in the Q&A as folks have questions. I think it's a really great question. So we're going to go through kind of the major domains of the neurobiology that impacts PTSD or helps result in PTSD. And a lot of it does require sort of retraining the brain, changing how brain regions talk to each other, and a lot of interesting treatment directions from there.
Underway then.
All right. Yep, it looks like my screen is showing. So thank you very, very much for having me today. And thank you again to Tom and Jen for sharing their stories, and especially Tom for sharing your experiences. You know, I think you really hit on a lot of the aspects of PTSD, PTS and PTSD that we think about in terms of developing better treatments. So I'm going to be spending a few minutes talking about the neurobiology of PTSD. We also have Sheila Rausch on the call today, who also can weigh in on this, and she'll tell me if I get anything wrong. So check the chat box in case Sheila wants to correct me on something. For those that care, I don't have many relevant conflicts of interest to disclose. I do get grant funding from the Brain Behavior Research Foundation, NIH and DA. I get royalties from the Oxford University Press and Up to Date. And it's important to know that a lot of the things, some of the things I'm going to talk on today are not actually approved by the US FDA for the treatment of PTSD and are only approved for research purposes in certain clinical trials. So, you know, Tom and Jen highlighted several of the aspects of PTSD that we think about, and those include intrusion, re-experiencing symptoms such as nightmares, flashbacks, having increased distress with reminders of the trauma, avoidance symptoms, so staying away from things that remind you of the trauma, or doing things to avoid thoughts of the trauma, negative changes in mood and thoughts, such as, you know, dissociative amnesia, negative beliefs about self, like I'm a bad person or I should have done something differently, negative mood and affect, and what we call anhedonia, decreased interest in activities, etc. And then alterations in arousal reactivity. So this includes sleep problems, hypervigilance, increased startle, can also lead to risky behavior, irritability, aggression. So these are all the symptoms that we think about when we think about the syndrome of PTSD. In thinking about the neurobiology of PTSD, it's really important that I feel that everyone realizes that all mental health conditions, whether it's depression, obsessive compulsive disorder, schizophrenia, addiction, Alzheimer's disease, and post-traumatic stress disorder, these are all brain-body conditions. So even though they have mental representations in terms of how people act, how people think, how people feel, these are fundamentally biological conditions as well. But they often involve multiple interacting biological systems. And so we're going to talk about these mechanisms in the next few minutes, but recognize that these systems don't operate separately. They all interact, and we'll talk a little bit about that as we go forward. Obviously, you know, post-traumatic stress relates to a stressor, so a traumatic experience, and so it invokes the stress hormone system. So that is clearly involved in the biology of PTSD. There are several neurotransmitters in the brain involved in attention, arousal, learning, memory, etc., that are also involved. Getting to the question of retraining the brain, we talk a lot about neural circuitry and how this can be thought of as a mechanism of action for potential treatments for PTSD, both at the micro level, in terms of how specific brain cells, neurons are talking to each other, and more on the macro level, thinking about how brain regions talk to each other as well. And I'll touch very briefly on inflammation. This is a mechanism that over the last several years, we're finding to be much more interesting in terms of its role in multiple psychiatric disorders, including post-traumatic stress disorder. So starting with the stress hormone system. So when you experience a stress or a stressor or a trauma, the brain releases chemicals, so corticotropin releasing hormone, that then lead to the release of other hormones that then act on the adrenal glands, which sit right above the kidneys, to to release cortisol. This triggers the stress hormone response. And this is part of the fight or flight response we'll come back to. It also interacts with the autonomic nervous system, the sympathetic nervous system, the parasympathetic nervous system. But these are the hormones that are fundamentally involved in responding to a stressor. Typically, when you experience a stressor, these are released, the stressor goes away, and these systems all effectively calm down. So all of these systems have basically safeguards in place that once the stressor is gone, the system should effectively shut down. So in the acute circumstance, increased cortisol prepares you for fight or flight. It decreases activity of the GI tract, the digestive system, the reproductive system, the immune system, basically shuts everything else down and gets the body ready to either fight or fly. In the brain, it also helps to increase attention to threat and helps contribute to responses to that threat, such as fear and arousal. Adrenaline is released as well, which also increases pulse, blood pressure, et cetera. Again, this intersects with the autonomic nervous systems. If this doesn't go away, so if that acute stress response does not go away as it should, then you can run into trouble. So a disrupted regulation of cortisol in particular has very complex actions on the body. So cortisol levels in patients with PTSD, they actually might be lower at baseline. So when you actually look at their cortisol levels at rest without the presence of a stressor, they actually may be lower than individuals without PTSD. But then if you actually stress them, you can see those levels go super high. So you see what we would interpret as a dysregulation of this stress hormone response. These could have long-term effects on the immune system and potentially long-term effects on brain structures and how brain structures work and function, so including the neurochemistry. When you have prolonged dysregulation of the autonomic nervous system, you may also see significant effects on the body as well. So two treatments that actually potentially could impact on this. And again, neither of these treatments that I'm going to talk about are approved by the Food and Drug Administration for the treatment of PTSD. Both are in active investigation, so they're actively being studied for PTSD, but these are not currently approved. One is vagus nerve stimulation, and this involves tying an electrode around the vagus nerve in the neck. This is a very interesting nerve that leads up to the autonomic, one of the cores of the autonomic nervous system in the brain, the locus coeruleus, which is a hub for the noradrenergic neurotransmission or the sympathetic nervous system. And you tie this nerve, tie the electrode around this nerve, and then you have a battery pack or a pulse generator that basically controls this electrode. The stimulation is chronic, so you have this going on constantly, but intermittent. So every few minutes, a stimulus will be delivered, wait a few minutes, the stimulus will be delivered again. This is FDA approved for epilepsy, depression, migraines, and I believe also cluster headaches. And again, it's being actively studied for PTSD. And the thought is this could be effective in helping with the parasympathetic dysfunction involved in PTSD. Switching to the sympathetic side, stellate ganglion blocks is a treatment that's received a lot of attention over the last few years. This was a treatment originally designed to treat pain syndromes, especially complex regional pain syndrome, previously known as reflex sympathetic dystrophy. The stellate ganglion is a bundle of cells that sit in the neck alongside the carotid artery. You'll see the cervical spine here. This is a major hub in the sympathetic nervous system. And the idea is to inject a local anesthetic to effectively numb this region. We don't know yet what effects this has on the sympathetic nervous system. There have been a lot of studies, mostly case reports and open label trials that have suggested benefit for stellate ganglion block for PTSD. There have been 2 sham or placebo-controlled studies of this as well. One was negative, but the most recent, it was mostly a DoD study, Department of Defense study, and active duty military primarily was positive. There are some challenges with these studies in terms of interpreting the data. And so I'm part of a group led by Michael Hollyfield out at Long Beach, California, to do a large multi-site study within the VA to see if stellate ganglion block does have benefit for PTSD, and especially do repeated injections work, and then what are the long-term benefits. We're also looking at mechanism. We think this might actually target hyperarousal specifically in PTSD, and so we're looking at that. Switching now to neurotransmitters, and so these are the brain chemicals that help control how brain cells talk to each other, and they basically are the bread and butter of how the brain communicates. The ones that have been implicated strongly in PTSD include what we call the larger group is called the monoamines, norepinephrine, serotonin, dopamine. These help regulate and fine-tune the brain activities, so they don't necessarily tell a neuron to fire, but they help modify whether or not it's going to fire with other stimulation coming in. These are very much involved in the regulation of mood, thought, and behavior, and have been implicated in essentially every psychiatric disorder, and therefore they've become the target for most of our psychiatric medications. Norepinephrine, as I said before, is produced in the locus coeruleus, which is in the brainstem, and really projects throughout the brain. So there are binding sites for norepinephrine everywhere in the brain. And so when you take a drug that affects norepinephrine, it's basically having effects anywhere in the brain. We do believe that norepinephrine has effects on arousal and emotional reactivity, which makes it relevant to PTSD. And it's also involved in learning. And so increased norepinephrine release has been associated with reminders of traumatic experiences. And so this helps validate its role in PTSD. The other major neurotransmitter that we think about is serotonin. Serotonin also produced in the brainstem and midbrain, but also projects throughout the entire brain, has been implicated in anxiety, panic attacks, flashbacks, and all of these may actually contribute to a role of serotonin in avoidance behavior as well. How do these have relevance in PTSD? So multiple studies have shown norepinephrine and serotonin are abnormally regulated in PTSD. And other systems that control these, such as the cortisol system, glutamate, GABA, other neurotransmitter systems, also interact with serotonin and norepinephrine. And again, most of our psychiatric medications target these systems, and in particular, antidepressant medications, which specifically target norepinephrine and serotonin, have been shown to be somewhat effective in PTSD. Currently recommended medications for treating PTSD include paroxetine, also known as Paxil, sertraline, known as Zoloft, fluoxetine, known as Prozac, and venlafaxine, known as Effexor. Most guidelines for the treatment of PTSD recommend these medications. Again, not after someone has tried, or not before someone has tried evidence-based psychotherapy. Again, I think as Tom and Jen mentioned, the importance of the evidence-based treatments out there for treating PTSD, we cannot say enough that things like prolonged exposure, cognitive processing therapy can be highly effective and really are considered first line. But if those are not effective, or if a person can't tolerate those, then these medications should be considered. Moving on to neural circuitry of PTSD. This is how brain regions talk to each other. This gets to the question of sort of retraining the brain. Again, at a very microscopic level, neurons talk to each other, again, via neurotransmitters. And one of the things we found is that stress can actually decrease the ability of neurons to talk to one another. We actually call this disrupted neuroplasticity. Again, the ability of the brain to learn and train these systems to talk better to one another. And when you have this stress-influenced decrease in this neuroplasticity, that leads to dysfunction of these brain systems. That can lead to changes in cognition, disruptions of memory, disruptions of learning, emotional regulation, et cetera. And again, thinking about this happening at a network level. Some medications may help reverse this. This is currently being studied. This is not, again, these are not FDA approved indications, but ketamine, which has actually shown a significant benefit for treating major depressive disorder, which also has deficits in neuroplasticity. Ketamine is being actively studied in the treatment of PTSD, both as a monotherapy, so giving ketamine just on its own, and then combining ketamine with other effective behavioral treatments, such as cognitive processing therapy or prolonged exposure. The idea being that ketamine, if it's affecting the way the brain, the neurons are talking to each other, if you give ketamine, maybe it'll actually enhance the way these other treatments are working. At a more macro level, we think about how brain regions talk to each other. And the best example is that we have great evidence that the prefrontal cortex, so in the front of the brain, actually regulates the activity of more deeper structures in the brain, such as the amygdala, which is very much involved in fear response, anxiety, emotional learning, et cetera, so that when you experience a traumatic event or a reminder of a traumatic event and have an emotional reaction, that is often largely driven by amygdala activity. And then the prefrontal cortex has a job in regulating that amygdala activity. So basically shutting it down and saying, no, that threat is not a real threat, and we should not react to that. And so if that interaction is dysfunctional in some way, then you basically have an amygdala that's reacting to a traumatic reminder, a prefrontal cortex that is not regulating that amygdala. And so then you have basically a response. You feel the need to respond to that threat. And this has absolutely been observed in PTSD. Multiple other neural network dysfunctions have been observed in PTSD. And then we think about treatments that might be able to affect that. And so brain imaging has greatly helped our ability to map out these networks. And so PET imaging, MRI, functional MRI, EEG, et cetera, have been used over the last 20 to 30 years to basically map out the brain regions involved in PTSD and treatment response to PTSD. And that's identified a number of regions that seem to be important. So the prefrontal cortex, which I mentioned before, is shown here. Sensory motor cortex, again, involved in how you're physically experiencing a situation. And again, amygdala, hippocampus, regions involved in experiencing, reacting to threats, anxiety, et cetera. And again, all of these regions need to interact normally to have normal responses. And if they're interacting abnormally, then you'll get dysfunctional responses, which we think is happening in patients with PTSD. So how can we interact with this? And so we have several brain stimulation techniques. I mentioned vagus nerve stimulation earlier. There's also a non-invasive technique called transcranial magnetic stimulation that targets the base superficial prefrontal cortex, and then can affect brain regions that are connected to it. And then if you want to target a deeper structure in the brain, there's deep brain stimulation. This is where you actually implant an electrode in the brain to a region that you want to target specifically, and that could also have benefit. Quickly on TMS. TMS, again, is non-invasive. It stimulates the surface of the prefrontal cortex in most cases. Repetitive TMS is given multiple pulses over a period of time, and then multiple sessions over time, over days. Clearly has effects on distant regions in the brain as well. So for example, it can affect the release of neurotransmitters and deeper brain structures. Again, non-invasive, unlike electroconvulsive therapy or shock therapy, which people may know of. It does not involve anesthesia. The patient is awake during the entire treatment. TMS clearly has shown some benefit for PTSD in several small studies. There's a lot of variability in these trials, and so we really don't know what the optimal parameters are yet for transcranial magnetic stimulation for treating PTSD. But again, getting back to the neuroplasticity idea, the thought of combining TMS with other behavioral interventions has been proposed, and there have been a couple of studies that have shown that this may be a useful approach. So for example, using TMS to say, drive up the prefrontal cortex and then doing a behavioral intervention that requires the prefrontal cortex to be engaged. And so you're basically priming the system with TMS, doing the behavioral intervention, and that may optimize the treatment itself. Multiple TMS devices are available. TMS is available in the VA for depression. It has been used off-label for PTSD, but I encourage you to look for clinical trials of TMS for PTSD if something like this is of interest. Deep brain stimulation. This is much more invasive. This is very, very experimental. This is approved for the treatment of Parkinson's disease, tremor, dystonia, and obsessive compulsive disorder. It's investigational currently for depression, post-traumatic stress disorder, and other conditions. But the idea is you do a surgery to implant an electrode into the brain, into whatever brain region you think is involved. It's a very small electrode, again, similar to VNS. Stimulation is driven by a battery pulse generator implanted in the chest wall, so the whole system is completely internalized. Again, established for certain neurologic conditions, available for obsessive compulsive disorder. There are some mixed data for treatment-resistant depression. There are animal studies and some early clinical data that it might also be beneficial for PTSD. There is a group in LA, so at the Greater LA VAMC, there's a group that's actually doing this currently for PTSD. Again, this is a study, but there might be other targets. So there, again, the amygdala, which is involved in fear and anxiety, is a very reasonable target, but there could be, as I was talking about the neural circuitry of PTSD, there could be other targets as well. In the study in LA, I mean, they haven't reported a lot of data yet. Their first patient they reported on a few years ago did very well, and we're just waiting for better, more data from that group. Finally, ending with inflammation. So this is something, inflammation is implicated in really almost all of our psychiatric disorders. So depression, schizophrenia, OCD, PTSD. And the idea is that the immune system, even though it regulates inflammation in the body, it's like when you get a cold or another infection, you get inflammation, head cold symptoms, et cetera. The same chemicals that are causing that in the body are also acting in the brain and can lead to changes in mood, thought, and behavior in the brain. There's absolutely data that the immune system dysfunction and inflammation are implicated in PTSD. Currently, we don't have any treatments that specifically target inflammation or immune function in PTSD, but there are several studies, excuse me, underway. There was a recent paper published by Brian Shiner, who's one of my colleagues here at White River Junction VA in Vermont, that suggested that hepatitis C anti-inflammatory or immune drugs could actually be effective in PTSD based on a review of VA data, clinical data, leads to sort of validating that this may actually be a very exciting direction for future research. So stay tuned for this. Again, no current treatments, but something that we are actively looking into. So with that, I will stop sharing and I will start looking at the chat. Sorry, I'm just scrolling through the questions in the chat here. I see a question about stellate ganglion block. Again, stellate ganglion block is not currently recommended for PTSD. There is a center that does it at Long Beach, California, VA, Long Beach VA in California. But keep your eyes open for a clinical trial of stellate ganglion block for PTSD in the VA. Outside of the VA, I don't know what the approach, I don't know how you would access the condition.
Yeah, we'll
Again,
talk about that in a minute. We got that. That's one of the speakers we have next.
Perfect, great. Yeah, Stripe, yeah, excellent. MDMA, so I have a number of slides on MDMA, cannabis, other psychedelics that I'm not going to go through today, but I'm happy to talk about those when we get to the Q&A at the end. Have you looked at MDMA in a control? Yes, MDMA has been looked at in a placebo-controlled setting. It's really complicated, and so MDMA is currently being combined with it's a unique approach to psychotherapy. So it's not one of the standard psychotherapies. Sheila may say more about this later, but I believe that Emory and is doing work on combining MDMA with another, a more traditional form of psychotherapy for PTSD. And so there are several other ways that this is going.
Yep, we are. I've got a study with MDMA combined with prolonged exposure, and then we actually have a THC trial. I have a THC trial with Wayne State University that's combining THC versus placebo with prolonged exposure.
And we will get to all these questions and that once we get through. I want to jump on off now and go on, let each program kind of go out so we're not repeating each other. So Dr. Holzheimer, are you, thank you for that. I know my partner here has a couple questions for you, right?
I'm good if we can hold them until the other folks do their presentations. And if you will, Dr. Holzheimer, if you'd stay with us, we'll move on and we'll get back to a kind of a round robin Q&A for all of our experts. Shall we move on to Dr. Craig Bryan?
I think so. I think we need to get going on the program.
He is a professor of psychiatry and behavioral health at the Ohio State College of Medicine. He specializes in trauma recovery and suicide prevention. Dr. Bryan.
Hello, good afternoon, everyone. Thanks for having me join today. I'll spend just a few minutes talking about some of our work at the Ohio State University, some of the research studies that we have going on and the treatments available as a part of those research studies. Our program here at the Ohio State is referred to as the Suicide and Trauma Reduction Initiative for Veterans, or STRIVE for short. One of the central treatments that we have been researching and testing over several years now is cognitive processing therapy. Cognitive processing therapy, or CPT for short, is one of the recommended psychotherapies, non-medication therapies that have been shown to be highly effective for reducing symptom severity of PTSD, and in a majority of cases, more than half of individuals with PTSD who complete the therapy will actually experience remission from PTSD, meaning they no longer can be diagnosed with PTSD. CPT as a therapy focuses on identifying patterns of thoughts and beliefs related to the traumatic experience, and the term that we use to describe these unhelpful or trauma-related beliefs are stuck points. They're referred to as stuck points because the idea is that what we tell ourselves, how we view the world, the beliefs that we have can in some cases lead us to become stuck in a traumatic experience within PTSD. And so a key target and focus of the treatment then is identifying those stuck points and developing alternative strategies, alternative thoughts, beliefs, and perspectives that can help someone to get unstuck from the trauma. One of the hallmarks of the research that we've been conducting here at the Ohio State University is to test CPT in a compressed or a masked format. So when CPT is traditionally done, it uses a kind of a more typical therapy format of, attending a 1-hour session every single week for maybe several months. And what we have been doing is compressing that into a 2-week window where service members and veterans can attend a 1-hour session every single day for 2 consecutive weeks. And what we've seen now in several research studies is that this leads to significant rapid reduction in PTSD, depression, as well as suicidal ideation. We have some of the graphs here on the right-hand side of my slide here are some of the results from various iterations of this treatment that we've done. And so we're consistently seeing very rapid recovery from PTSD. For those interested in contacting us, you can find us online. Our website is go.osu.edu/strive. You can also, of course, Google Strive at Ohio State University. And then our email is strive@osumc.edu. Typically, we will get back to you within about 24 to 72 hours. We'll do an initial screening, have you fill out some surveys, symptom checklists online. We review that, schedule you for a phone or a Zoom-based appointment with one of our psychologists to do a more thorough interview focused on PTSD. And based on that interview, if someone is eligible for a study, we can enroll them and get them started in treatment, typically within a week. The treatments are now delivered almost entirely virtually due to COVID restrictions. And so we are actually quite flexible geographically at this point. And so regardless of your location, we could potentially get you enrolled. We've had actually service members and veterans from all around the world, even in Europe, participate in our research studies and receive care. I wanted to highlight their newest study that has just started, kind of as a follow-up to the previous discussions on stellate ganglion block. This is a new project that has been sponsored and funded in part by the Navy SEAL Foundation. We just started enrolling veterans this month. The first handful have gone through the screening and assessment process. We're actually collaborating with the Stellate Institute with Dr. Jim Lynch, who will be speaking here shortly and provide a lot more detail about SGB. So we're really excited about this partnership. Veterans interested in this research study will receive trauma-focused therapy, CPT, as well as stellate ganglion block. What we're hoping to determine is, does a combination of these two treatments work better than either treatment alone? And then secondarily, we're looking at different sequencing types of questions, whereby we'd like to know, should the stellate ganglion block come before or after treatment? What might be the best way that we can recommend the combination of these treatment options for veterans? So shoot us an email if you're interested, strive@osumc.edu, not only for this study, but also other studies focused on trauma therapy. So thanks again, and I look forward to discussion and questions afterwards.
Dr. Bryant, thank you. And now let's move on to Dr. James Lynch. He's an MD, primary care sports medicine physician, and an Army veteran. He is a pioneer in the use of SGB to treat symptoms of post-traumatic stress.
Yeah, appreciate that invitation. I'm going to share my screen in a second. First, let me say, so it's difficult in this platform to see who's watching, who's in the audience. Certainly there are people in the audience who are watching that suffer from post-traumatic stress, who've been carrying around really heavy loads. And I don't want that to get lost when a bunch of doctors start talking about technical things and research subjects and stuff like that. I think there's no intent to lose the impersonal nature here. I think that to me, people who are suffering with invisible injuries from trauma are, it's real. It's not, a side project or some kind of a research, side interest or anything like that. Part of that comes from, just briefly on my background, I spent 31 years in the Army. I had 5 combat deployments. I came from the same unit as Tom Satterley, so I really appreciated to hear his comments. And my partner, Sean Mulvaney, is the same. Spent 31 years in the military, started out as a Navy SEAL and finished up his career as an Army physician, spent all of his time in special operations. So that's just the background of the lens that I see this through. Because of it, I've seen the personal effects of PTS on many people, and particularly the personal effect of people who have not yet come forward to ask for help, or who, as Tom said, who are in the won't, not can't stage. And so anyway, I just want to lead with that, because I think there may be some people that, are afraid that some of the providers that try to help heal may be wrapped up a little bit too much in technical things that involve always very invasive techniques or kind of, whiz bang things. So I hope that's okay and received all right. I'm going to share my screen here. My screen sharing is paused. 1 second, please. All right. All right, sorry about that. There we go. Okay, good news is I only have 3 slides. Just this first one here, I just want to show, for those of you who have never heard of stellate ganglion block, or what the heck is this thing, sometimes a picture is worth 1,000 words. So all this is a picture of me performing a procedure under ultrasound guidance. So here's ultrasound. There's a patient lying wide awake on their back who are comfortably getting a procedure that involves an injection in the side of the neck. So I'm going to describe that, but I think that's helpful just to see what the picture is for those of you who have never heard of what stellate ganglion block is. I only have 2 slides with a couple of bullets, and I don't, and I hope that this is really the bottom line. That's the goal. So like I said, the stellate ganglion block is simply a injection of local anesthetic in the neck which is designed to reset the fight or flight system. Something Dr. Holzheimer just hit on was he used the terminology, it was like to numb the cervical sympathetic trunk, which is, technically to describe what we're doing here is we actually put the nerve asleep that controls the fight or flight system. And as you've heard already from several of the other speakers today, what can happen is it can sometimes become dysfunctional so that the body's fight or flight system that used to operate fine was somehow exposed to trauma and then becomes stuck in the on position or doesn't work as well as it used to. With other nerves in the body, we've discovered for a long time that if we block a nerve and allow it to go to sleep and then reset itself, it can wake up in a less activated state. This has been known in medicine for a long time, but only until recently have we applied that to post-traumatic stress. So this is not a new concept. This is a very simple technique that's been tried and true that's now being applied to a new indication. So again, the next bullet down there, the stellate ganglion block's been used for over 100 years. There are people who hear of it and they think it's kind of a new treatment. It's not. It's been around for 100 years. The procedure's been performed blindly, meaning simply locating a bone in the neck and injecting it along your finger for 80 years before the advent of image guiding like fluoroscopy or ultrasound, which has now made it significantly safer. So just to feel comfortable about things, this is not some super invasive, very dangerous thing, nor is it very painful. Since about 2010, this third bullet here, we've used stellate ganglion block now in literally thousands of trauma survivors. Much of this work started off as a slow trickle in 2010. Again, my colleague, Dr. Mulvaney, and I were introduced the stellate ganglion block in the military. Dr. Mulvaney was really the first to break this into the military, and I give him great credit for that. Shortly thereafter, we performed a lot of stellate ganglion blocks. We tracked our outcomes. We worked very closely with our psychology colleagues, and we really kind of demonstrated that this was an effective technique, not in and of itself as a miracle cure, but rather to add into other things that already existed. So since that time, again, we've done thousands. We are now combined in a center here in Annapolis, Maryland, where Dr. Mulvaney and I do stellate ganglion blocks every day. The literature is pretty rich here. So you may get the impression that this is kind of an experimental thing, the way some others have described it. There is level 1A evidence to support this. So there are randomized controlled trials that show that the effect of the stellate ganglion block was actually twice that of a placebo or sham injection. And on the order of magnitude that it's significant clinically. So it's a big deal in terms of the effect. There are studies going on more and more, and there will be several, just like the one that we just spoke about with Ohio State and the STRIVE program, which I'm very excited to see. But there's really over 40 articles in the peer-reviewed literature. There's about 14 good individual studies that show that. Only 2 of them are randomized controlled trials. But like I said, the last one there that was just published in JAMA Psychiatry a couple of years ago showed that the effect of providing a stellate ganglion block was twice the effect of a placebo injection. Here is my last slide, which are the take-home points. So when I say what's the effect, what are we talking about here? What is the effect? So in the short period of time that it takes to conduct a stellate ganglion block, which is literally 10 minutes, without sedation, without pain, maybe some mild discomfort, without sedation or fancy equipment, a simple ultrasound is the safest way to do this. Fluoroscopy is used some places, which is live X-ray. But really the safest way to do it is under ultrasound and certainly not sedated. We know that having feedback from patients makes it a more safe procedure rather than someone who's just completely out of it. So the effects that we see just within hours, some folks minutes after a stellate ganglion block, is a rapid reduction in symptoms, about 50% drop in symptoms in the first day. And this is the case using a particular technique on the right side of the neck for about 80–85% of people. Brief mention here that for the other 15% of people who do not respond robustly with a right-sided stellate ganglion block, our studies have showed that if you take the people that don't respond really well on the right, about 90% of them will respond really well to a left-sided stellate ganglion block. And we don't really have time today to get into the intricacies of that. But for those of you who may have heard of someone who had a right-sided block that did not respond, or if you yourself have had that, there may be hope. And as we're discovering this a little bit more, the brain is a little more complicated than we think sometimes. The average effects on the symptom reduction is kind of all over the place, but the best thing I could give you for a rough estimate is somewhere around the 6 to 12 months range. People will get very good response of their symptoms. Shorter than that sometime if there are other events that re-trigger, or if people aren't really keeping up with their therapy, or if they are not keeping up with good healthy lifestyle changes, maybe symptoms will creep back up again a little sooner. If they are doing a good job, these will extend the effects of the stellate ganglion block, particularly if they're involved in good therapy with a therapist that they trust who has some background in trauma training, and they can really use that opportunity to dig in. So I really think that is the key role or the real niche here. And sometimes you get, sometimes the landscape is very confusing. If you are a trauma survivor, I don't care if you're a veteran, it doesn't matter. If you're a trauma survivor, and particularly, survivors of sexual trauma, repetitive trauma from as first responders get, childhood trauma, doesn't matter. If you're experiencing those symptoms and you're looking for answers, it can be a very confusing landscape. You'll hear one provider say something's better than the other. You hear this medicine something better than the other. One of the things that I think is most important that I could say today is it's very, very individualized, and there's no such one thing is better than the other. That's just not that true. There are some treatments that are just not that effective, like medications, frankly, that just, they work okay, but there's problems with them. And there are other things that are helpful as well. But this idea that this is a one treatment that's better than the other is kind of a myth. What I think is the way to look at it is what combination of therapies, and Tom mentioned this earlier, it's really, how do I combine all the weapons in my arsenal to get after my symptoms? And the one thing that you're not going to be able to get rid of is really digging in with good talk therapy. So I think many of these things, like stellate ganglion block in particular, help put you in a state that you can really dig into therapy. An example of this, the next bullet here, is we conducted a study, just really a survey to look at all the psychologists, particularly in the DoD, in the military, and in both the US and Europe. And we asked those psychologists and social workers who have treated clients of theirs who have had stellate ganglion block for PTS. We said, hey, what do you think? And we surveyed a bunch of questions, but I put the bottom line up here. 95% of the psychologists that have experience with SGB, who have treated their clients who have had an SGB, would recommend it to their other colleagues. And there's a lot more data in that particular survey that came out that was really reassuring that this is an extremely useful tool. It's not to replace something per se, and certainly not to replace therapy. But what it can do is really make the therapy more useful, more effective, and frankly, a lot more pleasant for the people who have a hard time stepping forward to ask for help. And that's just a simple thing. We looked at some fancy diagrams about the brain, but here's how it boils down to me. I'd like to leave you with this. There's some very complex circuitry in the brain. We know that. There are certain areas in the brain that are where trauma memories are stored. That's fine. Then there's your body that responds a certain way to trauma. It tenses up, it breaks out in a sweat, your heart races. They're very uncomfortable physical symptoms that you get with trauma memories and trauma experiences. Well, guess what? The neck is what connects both the brain and the body together. And there's a highway that runs between there that carries this signal between the brain and the body and the brain. And when that is elevated and dysfunctional and it doesn't work right, that's a perfect precision medicine target that we can do without having to go into your brain or implant things, not to talk down about those particular strategies. However, I'm kind of a simple guy, and I think if there's a way I can adequately get after the signal and break that circuit in an effective way, in a 10-minute procedure that's not very painful, and then you walk home feeling great, I think that's a pretty good option. Certainly, there's a lot of work to do in this area, but it's really a great option. The website is down at the bottom of your slide there, thestellateinstitute.com. Again, it's just Dr. Mulvaney and myself. We're located outside of Washington, D.C. We treat people every day in Annapolis with stellate ganglion blocks. I feel like if you have any questions at all, I'd encourage you to go to our website. Not only are there testimonials and frequently asked questions there, but we also hung all the evidence on the evidence tab as well. So I'm happy to take questions now, but there's a great wealth of information on the website too. Thank you.
Dr. Lynch, thank you. We will move on to our final presenter, but we would like to come back to you. We're going to have questions later. Let's go to Dr. Sheila Rausch. She is from Emory University, Deputy Director of Healthcare for the Veterans Program at Emory, and she is a professor of psychiatry and behavioral sciences. Dr. Rausch.
Thank you. And thank you very much for having me. I'm really excited to get the word out about our Emory Healthcare Veterans Program. I'll start off with just a little bit about myself. I'm a military spouse. My husband was an Army Ranger a long time ago. I've been doing work in PTSD for over 20 years. And basically when I saw those planes hitting the towers back on 9/11, I knew that we were going to be going to war, and I knew that that means some of our service members were going to need mental health help over the long haul. And that was when I decided to leave traditional academia at University of Pennsylvania and actually join the VA and work on setting up programs based on my knowledge of PTSD at that time. And my whole career up till this point is really trying to figure out what types of PTSD treatments work for whom, why they work, how they work, and how we can make them work better. And then the most important piece is how do we get those treatments to people who need them when they're willing to receive them. So I've done a lot of work on program development in the VA. And now what I'm going to talk with you about today and share my screen is our Emory Healthcare Veterans Program, which is sponsored by the Wounded Warrior Project, but it's outside of VA and provides free treatment to post 9/11. Anyone, if you've served one day post 9/11, you're eligible for this service. So let me share my screen. All right, so we are called the Emory Healthcare Veterans Program. We heal invisible wounds of war, all different types. Our primary focus is post-traumatic stress disorder, but that can look very different in different people. Moving on. There we go. So we really like to focus on the fact that the treatment programs that we come up with, basically when a veteran calls our line, which I think you see on the bottom of the screen, and you'll definitely see at the end of my slides, you call anytime or you fill out the form online. And within a day or two, you'll hear back from our initial contact person who is a veteran. And that person will do a brief phone screen with you to see whether the program seems like a pretty good fit. And then we set up a holistic multidisciplinary treatment program for each veteran that's very individualized. We take people from all over the world, just like Dr. Bryan said. We have seen people from all over the United States as well as outside of the US who are active duty. We treat PTSD, TBI, military sexual trauma, depression, anxiety-related invisible wounds of service. And the treatment options that we offer include standard, like normal weekly psychotherapy, but what we're really most proud of and what we really think is that transformative element of our program is our intensive outpatient program, where people come from all over for 2 weeks. They stay with us and go work through their individualized treatment program, either virtually through telehealth or with us when we're able to have pandemic conditions allow, when people are able to actually travel and come see us. We come up with these individual treatment plans that may include prolonged exposure therapy, which is a treatment that's excellent for post-traumatic stress disorder. Virtual reality exposure therapy is another kind of variation of that prolonged exposure using virtual reality. We also work with TMS, TDCS for pain, as well as for other mental health issues, behavioral change for alcohol and substance use. And then the glue that holds it all together is we have enhanced case management to help get people ready to come to us, as well as transition out to additional resources so that the gains that people make when they're in our program, they're able then to maintain over the long haul. And really what we think about in the Emory Healthcare Veterans Program is how do we use the best of evidence-based medicine to get this person the most change within that 2-week period. And at the same time as we're doing that and reducing their PTSD or their TBI issues or military sexual trauma issues, at the same time as reducing that, we're also working to increase their general coping resources, they're connecting with their community, they're reconnecting with their family so that they can maintain those changes over the long haul. And we do have data that shows that 80% of our veterans have clinically significant and large reductions in their symptoms, and those symptom changes are maintained out to a year later. So 75% of our IOP patients improve in just 2 weeks. 85% of them maintain those improvements out to 3 months and beyond. We have 93% retention rate in our IOP. Any kind of PTSD treatment that you look at, whether it's a drug or psychotherapy, rates of drop are very high, over 50%. So that is something that's really useful in these 2-week IOP programs that most of the IOP programs that we've talked about today that are doing these brief mass interventions would see those same kinds of retention benefits. We've also demonstrated reductions in suicidal ideation. So really, really transformative results, reducing those symptoms and also reducing the risk that people will want to hurt themselves over time. And what's also important is that it's at no cost to the veterans, the services that we offer, because of that generous funding from the Wounded Warrior Project. So my last slide is just how to connect with us. You can, if you're a patient who's interested, you can call that 888-514-5345 and speak with our patient care coordinator as that initial first step. Thank you very much.
Dr. Rush, thank you. We do have one more presenter that's an addition. It is Jarrett Langfit from Rush University. Jarrett, are you with us?
Yes, I'm here. Thank you. So,
go ahead.
Thanks so much. I'm happy to be coming to you from Chicago to talk about the Road Home program at Rush University Medical Center. Let me share my screen here. So again, I'm Jarrett. I'm an Army veteran and one of our trauma therapists here at the Road Home program. Here at the Road Home program, we offer both outpatient and intensive outpatient services to veterans and their family members. Much like the Emory program, we are also a Warrior Care Network member. So we are a part of this network of programs that is partnered with the Wounded Warrior Project to deliver evidence-based services to veterans and their family members. So our intensive outpatient program, it's a 2-week program that is located in Chicago. We are available to veterans all throughout the United States. So anyone from anywhere can come to this program. We serve veterans irrespective of their era of service or their discharge status. So we are not solely for post 9/11 veterans, although a majority of the people that we do see are post 9/11, and that's due in part to our strong connection with Wounded Warrior Project. So we do PTSD treatment here, primarily cognitive processing therapy, which has been covered pretty well already. There's also a component to our program in which family members can participate. Right now, that's being held via Zoom due to the pandemic. So there's a 2-day kind of webinar series for family members to provide psychoeducation, discuss a little bit more about CPT and about PTSD, and to help involve the family in the care planning process. So much like Emory and all the other Wounded Warrior Project, Warrior Care Network member programs, there's no cost for treatment, transportation, food, or lodging. We fly the veterans here. They're put up here in the Illinois Medical District in Chicago and provide meals and everything else that someone might need while they're here for those 2 weeks. So as you can see, we do have a national reach. We've had veterans come from every state and in some cases overseas. So far, we've served just over 3,100 veteran clients in our IOP alone. So what does our IOP look like? I would say those 2 weeks can be pretty rigorous. The IOP is, it consists of day-long programming beginning at 8 a.m., ending typically around 5 or 5:30. While they're here during the 2 weeks, the veterans attend cognitive processing therapy with their individual therapist twice a day. We also offer CPT in a group format. We have psychoeducation, art therapy, as well as some other kind of supplemental therapeutic modalities. We have mindfulness, yoga, acupuncture. We do have a chaplain on staff. Provides optional spiritual counseling. And a lot of the work that we do here focuses on aftercare, right? I mean, we're a 2-week program. We recognize that 2 weeks is a good amount of time for trauma treatment, but there will be work to do after the IOP. And so we have a team here to assist with comprehensive discharge planning so that when veterans leave here, they're prepared with all the resources they need to continue that recovery work. Our research suggests that our program has been very effective so far. About 80% of the veterans that we see have a substantial reduction in PTSD and depressive symptoms as measured by the PCL-5 and the PHQ-9. And our research up to this point indicates that those gains stick for at least a year. And that's not to say that they don't extend beyond that year mark, but just that that's what we have the research for at this moment. And when I say a substantial reduction, what we typically mean there is around a 10-point change in PCL scores, which measure PTSD symptoms, and about a 3-point change in PHQ scores. So that's what we mean when we say a substantial reduction. Also notably, we have high completion rates. About 92% of people who come to our IOP end up completing the full course of treatment. In addition to our high completion rates, we have high satisfaction rates. So the vast majority of veterans who come here feel that they received help that made a big difference in their lives. And about that same percent say that they're very satisfied with the clinical care that they receive here. So here are a few quotes from veterans who have come through the IOP program, kind of attesting to our care. So if you or someone you know is interested in coming to the Road Home program for 2 weeks of trauma therapy, it's pretty easy to reach out to us. You can reach us at 312-942-8387. And we are also at www.roadhomeprogram.org. Thanks so much.
And Jared, thank you. We appreciate that. Let's now open it up for questions. We've got several different platforms that this is being broadcast on, if you will. YouTube and LinkedIn and Facebook and websites and
Zoom.
So we're going to try to gather your questions wherever you're watching. If you could, in the comment section, talk to us, ask your questions, and we'll pass them along to our panelists.
And, you know, one thing I can say right off, we got a couple questions here that have come in during it. One is for Dr. Holzheimer. You talked a lot about the different trials that we have that are out there for PTSD. And, you know, I'm a person, I've been through, not me personally on this one, but if I've been through a bunch of treatments that have failed, how do I find out about these new treatments that may not be FDA approved yet, but I don't care. If I'm looking at taking my life, I'll take the chance of a treatment that works. So is there somewhere I can look into that?
Yeah, no, it's a great question. So first and foremost, clinicaltrials.gov, all one word, clinicaltrials.gov. And I'm not sure if I'm not sure if that resource was provided with this, but that is a way to search for treatment trials in any illness, psychiatric, non-psychiatric, and any modality. And then you can see if there's a clinical trial that is enrolling near you. Beyond that, talking to your provider and saying, I've tried prolonged exposure and I don't think it worked. I've tried the medications and I don't think they've worked. I would like to try something different to see what other treatments they might be able to talk with you about. And then the National Center for PTSD, ptsd.va.gov, and I know that is one of the resources I think provided. We actually talk about a lot of these treatments and have some resources for people who are looking for other interventions. And we have a consultation program that if your provider is, and this is on our website as well, if your provider is sort of at a loss about what to do next, they can contact the PTSD Consult program and say, I have this person, they've done this, it hasn't worked. Are there other options for them? Or they're interested in this treatment or that treatment. We can provide the most evidence-based response that is available. And that's something that's available to providers in the VA, outside of the VA, as long as they're treating veterans.
And one question, it's obvious from the discussion today, there is no one single silver bullet, if you will, that's going to cure or treat PTSD in all cases. But is it fair to say that maybe some of these treatments in combination is what you're looking at now? Not just one way of treating it, but taking a look at it from several different angles, whether it be drugs or intervention with like the ganglion block. If there are other ways that you can do it and do it in combination that might be more effective. Is this what you're exploring right now?
Well, and to a degree, I mean, as a physician, I think about treatment of a medical condition like PTSD the way I would think about any treatment of a medical condition. And so if you have cancer, for example, you want to get the most evidence-based treatment for that cancer that you can. And we have several very highly evidence-based treatments that are available, such as prolonged exposure, cognitive processing therapy, et cetera. And so those are really the first line treatments. And so I think, thinking about the treatment as what is the most effective treatment for the condition that I have is really the first step. If those treatments don't work, or if you feel like you just can't do those treatments, then there might be other strategies. And that's where talking to your provider, contacting us at the National Center for PTSD is a reasonable way to go, looking for research studies, et cetera. To your question specifically, we are absolutely looking at it. I know that Sheila and Barbara Rothbaum, who works with Sheila, are looking at ways to combine these treatments to optimize the effects. So can you combine medications such as ketamine or MDMA with psychotherapy to get a better effect? Can you combine brain stimulation such as transcranial magnetic stimulation with a therapy to get a better effect? The idea is that you can potentially get synergy between these treatments, but those are not evidence-based yet. I mean, we're in the stage of testing those treatments, and if they have showed themselves to be effective, then those will become part of the treatment algorithm that we have.
And that's so it's much like the same way we got PTSD is how we're going to fight it. You don't fight a war with one attack, you're attacking from all the different angles. So I think it's the same thing with PTS is we want to do that in as many ways as we can, get any help you can. I just, I want to share this. I just signed up for one of the trials, and it's going to be combining the CPT with the stellate ganglion block. And I've been to a bunch of different ones over the years, and here I am. So I'm excited to see what happens. It's the first one I've ever been involved in that they actually combine. So
Can I address that?
Craig, question for you that came in that you and I have actually talked, but it came over the computer is, do I have to face my event when I'm in CPT or any of the treatments that we're talking about? Are you going to make me remember that and walk through it? And, I know some of the exposure therapy does that. Is that the way yours works?
So they're specific to CPT. There are sort of like different approaches. The original version of CPT did have what's called an exposure component to it, where patients were asked to basically write out a narrative of their traumatic experience. Researchers subsequently tested, is that necessary for the treatment? So they've compared versions with that recounting of the story and versions without. And sort of the conclusion of that research is that both work. Pretty much the same. And so now the way that we do CPT here at Ohio State is most people prefer the option where there is not that inclusion of write out the story of what happened, but we offer that as an option, and we'll discuss that with each individual patient at the beginning of treatment. What we have found is that some people want to tell that story. They want to confront the memory, and we have an option available for that. Others don't want to pursue that course. We've got an option for them as well. So I think we're at a stage now with our trauma therapies where there are some viable options even for those who don't feel comfortable disclosing or recounting, kind of the specifics of their traumatic experience.
Perfect. Thank you. Here's another one that just came in. This is going to be kind of for any of the experts. Can a veteran that is dual diagnosed with substance abuse and PTSD attend some of these IOPs for the PTSD? If that is the diagnosed mental health, would the veteran have to complete an IOP for drug and alcohol prior to moving from a residential to a PTSD specific IOP?
So I'll speak to that a little bit, at least for the Warrior Care Network sites. And I think this is true for Craig's program too. We work with people with substance abuse. Actually for Emory, we work all the way up until the point where someone would need to go for detox. We see lots of dually diagnosed patients with substance abuse and alcohol abuse in our program. And the research actually supports that that's the best way for someone who has both PTSD and a substance abuse issue. The preferred treatment, the treatment that's most likely to impact both of those conditions, is to treat them together, not to split it out. So, yeah.
All right, awesome. Next question. Do the veterans need to be service-connected PTSD to attend your programs?
Nope. Not at all.
Kind of what I figured. Okay, we've got time for probably a couple more, and then one more, and then we'll shut down. And this one's more for Dr. Lynch. I think it's directed to you. Is it the thought or the hope of combining SGB with other treatments that will become a permanent solution? Or is it still going to be 6 to 12 months? We're looking at another injection. How are you? I mean, what do you think as far as the future of that goes, or do you know it all?
Yeah, great question. I appreciate that. I think, and this may be a little different from some comments that we may have just heard, but I do think the short answer is I think it'll require further studies. So that's easy. We need longer term studies to see the long-term effects. But to me, it's clearly evident in the hundreds and hundreds of patients that I keep track of that those who engage in good, high quality talk therapy of a variety of different types will have extension of their stellate ganglion block effects much further than those who do not. So there's definitely a synergistic thing going on, which is, I think, where I maybe differ a little bit in how others look at how to approach treatment. It's a little bit like combining therapies you know, for anyone that's had orthopedic surgery before, many times you go ahead of time and do prehab, right? Or do physical therapy ahead of time to strengthen the musculature before another procedure. And it's just in preparation for that. And their term did not come up today, but interventional psychiatry gets brought up occasionally with the idea that if we do things, they can then make the brain more plastic, which Dr. Holzheimer brought up that terminology. If we can do something to put the brain in a state where it can become more effective to heal, then that's a good thing. So that's where I look at stellate ganglion blocks niche among some others that are also being potentially studied for usefulness. But I think that's different than saying, well, if you've tried all these things and they've all failed, then maybe you should try this other thing. To me, that doesn't make sense. In most of other medicine, we'll attack things with a variety of other treatments in parallel. So I do think, particularly with the individual variability in PTSD, it's very hard to study something that's so heterogeneous. There's 636,000 different combinations of symptoms that can get you to the diagnosis of PTSD. It's very, very hard to study that with such a regimented randomized controlled trial to then tease out what's good for everyone. So I'm just acknowledging, I'm not throwing my hands up in any way. I just think that a less dogmatic approach for this particular topic in medicine can be quite helpful by combining treatments that may make the therapy that's proven even more effective and for the duration to last longer. I hope that answers the question.
Oh, heck yeah, guys, we are running out of time here. Zoom's going to shut us down. I want to thank everybody for being here, Brent, and I want to thank our partners at CBS. This has been awesome. Thank you all so much for being here.
Thank you.
Thank you all.